Welcome friends, welcome colleagues, welcome viewers to MuniMeterHealth, your source of learning about human heart and its illnesses, awareness, and of course cardiology. So welcome again to MuniMeterHealth. Today in this segment, very briefly, we're going to be talking to you about what is myocarditis. Now, just so that everyone knows here, which I always say, some housekeeping rules. This is purely an educational channel, and it's mainly for medical education, patient education, and it's not a medical advice site. So just so that you know. All right, so moving forward, what is myocarditis? Myocarditis is essentially inflammation of the myocardium, which is your heart muscle. Itis, remember, is inflammation. Just remember that. That's good for the students. And myo, you know, is your myocardium, which is your heart muscle. Now, the heart is, remember, heart has, if you just draw the left ventricle here, for instance, we're not drawing the entire heart right now, just the left ventricle. Here is your heart muscle. In this fashion it goes, this being your left ventricle. So the inner lining we can show with another color if you like, and the inner lining is your endocardium right here. So that becomes your endocardium, which is the inner lining. This is your myocardium. This is your heart muscle, in other words. So this is what we are discussing. And then there is an outer lining which we can show if you like in another color. And that is right here outside, right next to the outer layer of the muscle, and that layer is called the pericardium. So pericardium, myocardium, endocardium. Endocardium is the innermost lining. So we are discussing the myocardium right here, and this is your heart muscle, as I just pointed out. So when this gets inflamed for whatever reasons, and we'll just talk about that, what are the reasons, that is called myocarditis. Now, what is the etiology? In other words, what are the agents that cause this to happen? Well, the inflammation can occur because of several reasons. One is viral. We'll just write viral. And in the viruses, we are going to talk about the adenoviruses, the echoviruses, the Coxsackie viruses, influenza virus, mumps, measles, and rubella, specifically in pediatric age groups. Influenza in the elderly, specifically. So remember that myocarditis tends to occur mostly in people who are very, very young, or they are very elderly. Sometimes they are malnourished, sometimes they are immune compromised. So there has to be some tendency, some precursor, some predisposition in order to develop a myocarditis. Not all patients who have influenza develop that. Not all patients who have measles develop that. So there has to be some predilection for that. Okay, now bacterial causes. Let's do the bacterial causes. Very importantly, diphtheria again in the young children, okay, like I just mentioned, and Mycobacterium avium intracellularly. Remember that. So one is diphtheria, I just said, and the other is MAI. It's very commonly present in HIV patients also, so because they're immune compromised. And lots of very serious infections like pneumococcal infections, which causes pneumonia, the gonococcal infections that causes gonorrhea. Then you have meningococcal infections that call meningitis. So all of these can also actually go to the myocardium and cause myocarditis. These are very, very serious bacterial infections, just so that you know. Next we have is a fungal infection, and the fungal infections can be the prototypes. Well, I just want to mention two of them. One is Candida, and the other one is Cryptococcus. So Candida and Cryptococcus, these are the two other kinds of fungal. Rickettsial and helminthic and spirochetal and protozoal, we're not going to get into those details because they're very rare ones. But the very fact that a lot of agents, viral predominantly is the biggest that takes the list. Now, what happens next? Let's understand what is the pathology. So between day 0 to day 3, what happens is there are a lot of macrophages that will start to accumulate within the myocardial cells. There will be viremia. That means the blood cultures will be positive, right? Blood cultures will be positive for certain specific viruses if you were to draw the bloods. This is the time when the person is also having fever and chills. So it initiates like almost like a viral illness, and but the prodromes are very, very sort of non-specific initially, and one does not until one suspects it. Now between 3 to now here we go. Let me just make that very, very clear here. So now once we have between day 5 and day 10, if you were to look at this is where the antigen reaction starts to occur within the myocardium right here, and the antigens which are commonly present are the ones which have so the antibodies will be in the setting that they will be either in secondary to the myosin. So this is where the antibodies will start to form against this antigen, the myosin. The sarcolemma, again, these are various proteins or various parts of the myocytes within the myocardial cells. Remember that. And then you could have antigens also within the armamentarium of the cell itself, like the actin or the myosin, etc. So we just talked about those. So these are the antigens. And starting in sorry about this little quiver here, and day 14 and past, you will have the antibodies which will be specific to any of these viruses or any of these antigens as well. So just remember that the antibodies will start to manifest within 2 weeks, and they will be peaking if you were to draw the graph here. All right, now the other two other myocardial markers will be present. What are the myocardial markers? Well, the markers which will define that there is some injury happening to the, whenever there is an inflammation, remember, there is an injury happening to the myocardial cells. So the troponin elevations will occur. The CPK MB elevations will occur. These are the various enzymes that we normally see. And then there will be other myocardial markers that could also be elevated. Now, what are the clinical features? The clinical features, as we talk about, they are chiefly patient will have obviously a fever, malaise, and then of course tachycardia. The heart rate will be rapid in most patients, and a gallop can be heard, so you can hear an S3 gallop. But many times what happens is the sine qua non of most physical examination, if I was to say, for the myocarditis, is the heart sounds will be muffled. That means you will not hear the lubbed up, lubbed up, lubbed up. You will hear very soft lubbed up, lubbed up, lubbed up, like that. So heart sounds will be profoundly muffled. Now echo, if you were to do an echo in these patients, they may have a global LV dysfunction. So LVEF may be down. Obviously, normal is about 50%, just so that you know, FYI. So this will be down, and it will be less than 45% or so. And chest X-ray may reveal signs of congestive heart failure. You may have bilateral infiltrates. You may have pneumonias if it's related to various pneumonitis. If it is related to diphtheritic pneumonia. If it is related to pneumococcal pneumonia, what have you, etc. So depending upon what the etiology of the this is, that will define that. Now ECG again will only show some it'll show some T wave abnormalities which could indicate an acute injury. Again, all signs of acute myocardial injury may be present, almost like a myocardial infarction, but T waves may be upright, and some ST elevations can be also present. But non-specific ST changes are usually normally seen. So just so that you know, non-specific STT changes are normally present more often. Having said that, what is the treatment? Now, obviously, the treatment is once you confirm the diagnosis based on... Now, I forgot to mention of the biopsies. Biopsies are rarely performed because now today you have non-invasively these cultures. You have an echo, which is defining the LV dysfunction. You have the sorry about this again, and pardon me, but the very fact is that you will have all of this happening in that regard. So RV biopsies can be done, but normally the RV biopsies are again 60% only sensitive or specific, because remember, the myocardium could be damaged here, for instance, and may not be damaged here. So if you were to take a biopsy, normally you take the biopsy from the RV, not from the LV, obviously, because the route is usually from the femoral veins or from the jugular veins, and that's where the catheters are passed into the right ventricle, and that's where the biopsies are normally taken. Okay, so biopsies are again they're present, then obviously the diagnosis is clinched. But if absence negative does not mean that there is no myocarditis. Okay. Again, normally myocarditis is also accompanied by pericarditis, accompanied by endocarditis, so just be leery of the fact. Treatment is normally geared towards heart failure management, and wonder why we have a little instability in our system today for some reason, but in any case, so treatment is geared towards heart failure treatment, and obviously diuretics are the way to go. You can use ACE inhibitors, you can use ARBs for support, and many times if the patient is having an impending cardiogenic shock, one tends to use intra-aortic balloon pump as well, and sometimes even an LVAD is prescribed, especially in patients who are impendingly not showing signs of improvement at all. Immunosuppressives may be used, but the fact that they are they cause more toxins and more toxic effects, therefore immunosuppressives have not been really a mainstay. But again, in push comes to shove and you have no other armamentarium left, heart failure and other treatment modalities have been tried, then immunosuppressives, specifically the prednisone or even the other immunosuppressive agents, can be tried. So in a nutshell, you've learned about myocarditis, which is inflammation of the myocardium. The etiological agents mostly are viral, but there are numerous bacterial and fungal and protozoal and rickettsial regions. Pathology is usually showing signs of autoimmune antigens between the day 5 and day 10 to the myocardial cells, and past day 14 you'll have the antibody titers, which can be ascertained. EKG, X-ray, and chest X-ray, again, they are not very specific, but they're very contributory if to support your diagnosis. Biopsy, if it is positive, obviously it is supportive, but if it is not, then here we are with our I just want to make sure we have this taken care of, and yeah, 1 second, and we'll have this here. Thank you. Okay, so this is where we are, and again, this is purely an educational channel. It's not a medical advice, so please stay tuned to MuniMeterHealth, your source for learning about human heart, illness, awareness, and of course cardiology. Thank you. This is Dr.